evening. I'm Melisa Idris. Welcome to Consider This. This is the show where we want you to consider and then reconsider what you know of the news of the day. A new policy paper by the think tank IDEAS Malaysia is renewing attention on a difficult reality. While medical breakthroughs now offer life-saving treatments for rare diseases, many Malaysian patients remain unable to access them due to high costs and systemic gaps. Last year, the Ministry of Health unveiled its national policy for rare diseases, marking a first for Malaysia in recognizing rare diseases at the national policy level. So the question we want to ask today is whether or not the health system is ready to deliver. Is Malaysia structurally prepared to support patients with rare diseases, not just in policy, but in practice? So joining me on the show today, I have the author of the paper, Durrah Sharifah Ahmad Azlan, who is a senior research executive at IDEAS Malaysia, and Nadiah Hanim Abdul Latif, president of the Malaysian Rare Disorder Society. She's also the regional representative of the Phelan-McDermott Syndrome Foundation and a board council member of Rare Disease International. Welcome to the show, both of you. It's good of you to join me. I'm going to begin with you, Nadiah. Maybe we can take a look at what is described as rare diseases. And I'm curious to know, how rare are they? How significant is the rare disease burden in Malaysia today?
Let's start with an interesting paradox. When we talk about rare diseases are basically defined as conditions that are individually rare or few in a particular society. So the WHO defines it as a birth of 1 in every 4,000 or more. So we know that collectively this number for individual diseases might be small, or disorders might be small. But collectively, they are far from rare. So here's the fun fact. When we talk about rare diseases, in Malaysia we call it penyakit jarang jumpa. According to the Ministry of Health, we have about close to 500 diseases that have been considered as rare diseases, that is identified by the Ministry of Health, and upwards of 12,000 patients that are seeking assistance in our healthcare systems to date. Now that's not inclusive of the fact that rare diseases across the world, as acknowledged by WHO, is actually between 7,000 to 8,000 diseases. So Malaysia is actually quite far off the actual number that is being defined as the WHO. And if you could guess, the number of people living with rare diseases in the world right now is 300 million plus worldwide. That's exponentially larger than the population of Malaysia. And if we combine this, a lot of people don't realize this, but the number of people living with HIV plus the number of people living with cancer, times that by 3, is still less than the number of people living with rare diseases in the world. Yes.
Wow. Wait, so why are the Malaysian numbers far off from the WHO estimates? What explains this discrepancy?
I think the easiest thing to do is, to your point, the system. Is it ready to diagnose? Is it ready to identify patients that are currently falling through the cracks? And we don't like to call them patients, actually. We call them individuals living with rare disease, or persons living with rare diseases. And the reality of it is, if a system is not able to detect, not able to diagnose, not able to identify them early, then the chances of misdiagnosis, which you'll see, is exponential, and a lot of them actually, more of them go through life without ever knowing what their actual conditions are.
Okay, so there is a data gap here, and which is why researchers like yourself are really important, Durrah. Your report that you put out recently used spinal muscular atrophy as a case study, and I'm curious to know why. Why SMA? Why was that an example for looking at how the health system responds to rare diseases?
Right, I think continuing on with what was mentioned by Nadiah earlier, so 72% of rare diseases are genetic in nature. So all over the world, we see research being done to develop gene therapies targeting specific genes causing this kind of rare diseases. So in comparison to other treatments, for example, the intention for these gene therapies is that it's a one-off treatment. So, but then it comes with a caveat that they are very costly. So all over the world, we have like around 4,000 plus gene therapies in the pipeline. And the ones that have been approved so far, from the last time that I checked, is like 48. And in Malaysia, only one has been approved, which is for spinal muscular atrophy. So we wanted to use this, SMA as a case study to explore innovative financing and outcome-based models that can be replicated for other high-cost rare diseases in the future. So it's like a blueprint, perhaps, for incoming gene therapies, which might be accessible in Malaysia in the future.
Excellent. Yeah. Okay, so really kind of using this as an example or a precedent.
Yeah.
When you say it's very costly, can you give me an example of how costly?
Right. So the one that has been approved in Malaysia, the cost is 9 million ringgit, and it used to be the most expensive treatment in the world at one point, but now I think there's 10 more has overpassed that price.
Is that 9 million per individual?
Yes.
Wow, that is, thank you for giving me some context. Okay.
Yeah.
How did you, Nadiah, come to be involved in looking at or advocating for a change in the system when addressing rare diseases?
Well, I think when we're talking about rare diseases, my first foray into this was working with undocumented stateless refugees, and then it became persons with disability, and then it became persons with complex medical diseases. And when you're looking at the vulnerable population or the marginalized in Malaysia and the compounded challenges that they often have, it's very difficult to kind of leraikan, right, split one issue over the other.
Intersectionality, right?
The intersectionality is huge. But when we're talking about why it was a huge red flag on there is a need for systems change, is because within the population of individuals living with rare diseases are the stories of families, of taxpayers, of people who are actually productive, who are contributing to the economy. One of the greatest issues that we have is the barrier of stigma, the assumption that you're broken individuals, that you're a patient, therefore you need fixing.
Okay.
Whereas persons living with rare diseases, many of them are actually, for the lack of a better word, able-bodied. You wouldn't know that they have rare disease unless they disclosed it to you. They're actually caregivers themselves. In fact, some of them have complex medical needs and are caregiving for people with non-rare diseases, but also needs. And what you see is this is a huge missed opportunity for the country if we're only looking at it from the context of medical cost. And this is why we're advocating for a whole system overhaul, because when you're talking to the rare disease families, what you would find is while 70% actually manifest in childhood, that means the other 30% are actually working adults or adults in that productive age contributing back to the economy. And we know that Malaysia is an aging population, therefore it's an incoming challenge where our children are transitioning into adulthood and our adults who are aging are caring for either transitioning or adults and aging people with complex medical needs. So to me it's a huge red flag on what the country is going to have to face if we don't start thinking about this now. Because just last November, the Minister of Health had declared himself in his speech at the Southeast Asia Rare Disease Policy Forum that they're looking at across approximately 1 million people in Malaysia affected by rare diseases, one way or another.
Okay, it really does put into perspective why this has been almost an invisible category of people that we need to include in our public health. You said something a bit earlier that caught my attention about diagnosis and how it can take a really long time. Why does it take such a long time for a diagnosis, and why is that such a persistent problem?
Okay, so it goes back to the system issue. Most individuals living with rare diseases across the world, and so in Malaysia, take about 5 to 7 years to get an accurate diagnosis. Very often their conditions mimic other things. So it's not uncommon for parents to get a diagnosis of global developmental delay or even autism spectrum disorder when that's actually just a symptom of an underlying more sinister issue that you have not been able to detect. Now, because 70% of these diseases are genetic, that means you probably need either a geneticist or a medical specialist that thinks, hang on, let's do one step ahead, what's there? However, what a lot of people don't realize is out of that, another 30+% are actually caused by anything else. So it could actually be conditions, it could actually be an onset of illness, it could be environment, which is what we're also seeing today. So not all of that is genetic, and therefore not all of them are hereditary. So we have this tweak that we need to do, because a lot of people assume that if it's genetic, therefore it's hereditary, which is not true. And so we don't have the doctors to be able to identify. We don't necessarily have the number of labs and technicians and people who are able to read the reports. And then therefore it goes into the system of, do we have enough talent? Do we have enough system processing? Once you get the diagnosis, what happens then? And then the follow through. So it's a whole chain reaction. It's not just whether or not you got the diagnosis. So quite a lot of our patients end up finding their diagnosis abroad or after having sent their medical samples abroad.
Oh, that's a shame. So how do we, and I'm sure if they're doing this abroad, the financing for that is even worse. So Durrah, in your report, you looked at innovative financing. You proposed outcome-based payment models. In simple terms, what does that mean? And how do you put it in practice?
Right. I think before elaborating on that, so the report does not outrightly suggest OBPM, but it works for treatments in which the outcomes are unpredictable. So I'll explain it further. So usually when government buys or procures a medicine, they would pay the full price upfront, but then for the gene therapy with the cost, for example, that would be impossible. So a simple definition of outcomes-based payment model, OBPM, is like a pay-for-performance model, meaning that the full price is spread over a number of years, let's say 5 years. Some countries have been doing that. And then the government would pay in stages based on an agreed milestones or outcomes. So let's say by maybe in the middle of it, second year, third year, the milestones are not achieved. So that could be survival, for example, or there exist complications, side effects from the treatment. So the agreement is that the government would not need to pay the rest of the cost.
Okay.
So there's this kind of risk-sharing model for outcomes-based payment model.
Okay, so for each of the milestones, there's a kind of reassessment.
Yeah.
Talk to me about why this is what you're proposing, why this works. What other options are there? If I'm not mistaken, Malaysia had something called was it Rare Disease Fund?
Yeah.
A trust fund, if I'm not mistaken.
Yeah.
Why wouldn't something like that work compared to what you're proposing with the outcomes-based model?
Actually, Nadia would like to add.
Yeah, Nadia.
No, go ahead.
I guess
Go ahead.
basically maybe it's not enough, I would say.
Okay.
So even the budget for Ministry of Health for rare diseases, from our conversations with people from the Ministry of Health, it doesn't encompass all rare diseases. So there is a need for more innovative financing model to cover more rare diseases. Yeah.
Nadia?
Okay, not making anyone sound bad, but just stating facts as it is. The National Rare Disease Trust Fund was really a breakthrough when we did it, because the intention of the government of Malaysia was to entice shared responsibility for the issue. They knew, and the government of Malaysia is very clear about the fact that it's not going to be able to fund every rare disease in every space in the country. So the intention at that point in time was, can we crowdfund together? That was what the trust fund was about. Now, understanding that out of the 7,000 plus rare diseases, 95% actually do not have any therapeutic intervention. So the OBPM that we're talking about today is for that 5% of those that actually do have some form of medical intervention. So the other 95% of those living with rare diseases actually don't have any kind of cure, any kind of medication. It's more of how to live a life well lived. So it's not true to say that all rare diseases are expensive, which is a very common misconception and a miscommunication that happens a lot. But for that 5% that do have intervention, because it might not be necessarily commercially lucrative to produce en masse, this price becomes tak mampu milik. It's not something that can be achieved by the average Malaysian. And we're talking about anywhere upwards from a few 100,000 per annum for the rest of your life to one-off in the quantum of millions, depending on what it is that you need. So SMA is one of the most researched rare diseases in the world, and that's amazing because this breakthrough helps it to kind of push the forefront for everyone else.
Yeah.
So when we're talking about the trust fund, the straight answer to that is because there isn't enough in there to even fund long-term the number of patients that are coming in and the number of patients that are being diagnosed versus the money that's coming out.
Right. So, because I think what one of the, I don't know, maybe this is a misconception, but there's thinking that rare diseases ought to be maybe looked at from an international, global level rather than using limited national resources. So some of the anecdotal comments that I've heard when discussing rare diseases is that, oh, why is it that we are looking at this from a national resources level? Why can't we look at it from, say, a global WHO coordinated response? Is
regional
that, even regional through ASEAN. Is that something that you've come across before?
Yes, actually I can answer that. Last May, MIDS was part of Rare Disease International. We represented Malaysia alongside the Ministry of Health. We collectively, the world actually managed to push for the resolution for rare, which was the first global resolution on rare diseases at the World Health Assembly resolution, and the first of its kind to reach consensus without any dissent.
Oh,
so that was the first. That was last year. That was a milestone for us, and when we brought that back, that was when MOH then launched its national policy. So it was on the back of the fact that the world is now understanding that there are many complex medical needs that deserve attention, not as just the flavor of the month for WHA, but something that's there on the agenda every year. So that's number one. Now the next point is what happens with the Global Action Plan. The Global Action Plan at its best is a declaration of a statement of intent, what the world wants to do. Now what it needs to do is translate into what it's going to mean for ASEAN, for us specifically, and then what it means for us at a national level. So last year in November, which is why I quoted the Minister of Health, is that Malaysia has agreed to lead the charge for ASEAN to push for an ASEAN declaration of rare diseases, which is meant to happen in the next 12 to 24 months, while it's still the chair for the ASEAN health cluster.
Okay.
Now that then ties into our National Action Plan for Rare Diseases, which needs to be brought forth so that the National Action Plan for Rare Disease actually talks about funding and innovative financing and diagnostics and talent development and labs. As you mentioned, as you rightly pointed out, the issue of cost or value being sort of siphoned out to other countries because of the fact that we're using other labs, that's also addressed in the policy actually. The national policy talks about developing the local talent and lab capacities in the country so that a lot of these diagnostics and therapeutics that actually can be done, or at least the diagnostics and the testing can be done locally.
Your report looked at other areas, so I think financing was just one part, and then you highlighted clinical readiness as part of the developing local talent. You talked about registries and newborn screening. I'm very curious about these system foundations. Why are they critical? How do they complement?
Right, so for registries, clinical readiness, newborn screening, so they're very critical, of course. For example, newborn screening is important because early intervention is important. I think there's a past report by a patient advocacy group, SMA Care, where they talked about how 90% of the damage to the nerves from SMA, for example, happens within the first 6 months. So having that early newborn screening is really critical so that you get to administer the treatment for them early, which is lacking in Malaysia for now. So clinical readiness too, as what Nadia mentioned just now, we are lacking in specialists. Some hospitals are still unaware about rare diseases, about SMA. We've had interviews with parents who talked about the differences in treatment between their child, their child who passed away before, due to the hospital not being able to manage the case well, because due to the lack of awareness as compared to other hospitals, which is a bit concentrated in Klang Valley. So this clinical readiness is really important, especially to not exclude rare disease families in rural areas, in other states. We had a conversation with Prof. Zilfalil Alwi from Kelantan, who is an expert in rare disease. He mentioned about how in Kelantan itself, there's a lack of specialists for rare diseases. So that's on clinical readiness. Was there one more?
Newborn screening.
Newborn screening, registries.
So many great ideas in the report.
Like our genetic counselors, medical social workers.
Because it's beyond just administering the treatment. It's also about the physiotherapy. It's also about the diet as well. We need dietitians.
Nadia?
yeah.
If I may share
Sure,
sort of
yeah.
a real life story of an SMA family in Kuching, which we visited a few years back. Now, what really hit me was the fact that she was actually a nurse that was actually in charge of the ER. This was the mother, and the father was a police officer, bertugas di Semenanjung, right? Unfortunately, when the child was diagnosed with spinal muscular atrophy, there was not the necessary expertise that was available there at the hospital that the child was at, and by then the child had developed into having pneumonia. So anything with lung infection and respiratory challenges, especially for a lot of these rare diseases, is dangerous, for the lack of a better word. And the mother was told that if you need help, you might want to contact the SMA associations in KL, because this is going to go into palliative care. We don't have the necessary means to assist your child. If not, you might want to fly your child to Kuala Lumpur. That naturally never happened, and the child passed. So when we met the family, the grief of having a mother who is actually a healthcare professional, knowing that her child is in the system and having the doctors tell her there's nothing we can do, despite the fact that we know that there is an orphan drug, we know that there are things that can be done.
Yeah.
But by the time you diagnose, because she was SMA type 1, it was too late as an onset. Yeah.
When policies are designed, do you think they take into consideration the lived experiences of families, of people living with rare diseases, of people with complex medical needs? Are they heard? Are they taken into consideration? Because I do wonder about that. You're nodding, Nadia. What do you think?
They do, but I think it can be better.
Yeah.
And the reason why I say this is because just the landscape of how rare diseases have progressed in Malaysia is, I'd say it's really dynamic. We now have more than 20 different associations championing rare diseases. Very often they are championing specific rare diseases or a cluster of rare diseases of the same sort. So MRDS is one of the few that basically look at cross diseases, so we really don't care what rare disease that is. And we work together with NCDs, the neurodiverse group, the cancer group, because we do feel that a lot of these conditions actually do, like you said, the intersectionality is huge. But at the same time, when we're talking about driving policy change, my concern is that when we develop policies, we're developing policies in isolations of the ambit of the different ministries. When we're talking about solving a problem of equitable health, we cannot just stop at the Ministry of Health. A huge chunk of this debate also sits with the Ministry of Higher Education, where our teaching hospitals actually sit under. So the ambit and the purview of our research hospitals like PPUM or UMMC, HUKM, TAPTA, all this, even where Prof. Zafala is at in Korean, right, USM. These hospitals rely on not only the budget, but the mandate from the Ministry of Higher Education, not necessarily the Ministry of Health. So what we're seeing is that equity among the service provision institutes within the healthcare system is also not aligned. We also have the military hospitals, we also have the private hospitals, we also have the outpost for the health district clinics, etc. So when we're talking about whole system, we're talking about cut across all these different ministries. And then we also have the Ministry of Education. We also have the Ministry of Women, Family and Community Development. Because if I were to just map it out, the minute your child is born, it will be under JPN, and then it goes into the Ministry of Women, Children and Family Commitment as kanak-kanak, right, until 4. And then if the child progresses and then goes into schooling age, then it's Ministry of Education. You're talking about inclusive education. And we have so many children living with rare diseases who are unable to go to school because they're not necessarily independent to be able to do whatever they need to do. That means that caregivers and parents who perhaps are even rare disease individuals themselves are having to make very difficult choices about, do I put this money that I have for the medication of my child, or do I put the child to school? If I put the child to school and not have the medication, I will have other costs involved in future that I have to deal with. If I keep the child at home and I pay for the medication, what about the other siblings that also need to? So this daily battle cuts across everything from the Ministry of Human Resources, the Ministry of Finance, of course, is a huge stakeholder that we have. In fact, fun fact, we even have issues with the Ministry of Home Affairs because in terms of pendaftaran, some babies who are born with unassigned gender because of rare disease are not able to get birth certs.
Wow.
So when we're talking about outcome-based payment model, back to what IDEAS was researching, we feel that if there is a rare disease that's already, moving the dial, and we have data sets coming from other countries of what good can look like, let's see how
Which is why this is a great blueprint
Yes.
of what we
Yeah,
want
yeah.
to see within the systems change. In the couple minutes that I have left, I'm going to leave it with you, Durrah. What, having put together this report and spearheaded it,
Yeah.
I'm curious to know what you would like policymakers to take away from this.
I think number one, really, it needs to be patient-centric. Of course, you cannot leave them out, like what Nadiah mentioned just now. I think adding on to what you mentioned also, I think the parents that we engage with, for example, from the SMA Malaysia Association, they talk about the psychological burden that the parents face. Some of them have to resign, have to retire early and whatnot. So you really should look at it from a holistic approach about the impact, the quality of life towards parents too. And then secondly, I would also recommend, that's all the basic things that was mentioned just now, the newborn screening, national registry, clinical readiness, that needs to be put in place beforehand. And then I think this might be something uncomfortable too. I think that more negotiation should be done between the government and the providers of these treatments because
To
research...
get a better deal?
True. Yes, because we see in the development of this kind of treatments overseas, through the early research, a lot of them were actually funded through public taxes, charities, crowdfunding, and whatnot. So I think it would be good for the government to negotiate on the cost based on that too.
Yeah, great. Thank you so much, both of you, for sharing some of your insights and also educating us all on how to view this matter going forward. Thank you for your time. I appreciate you. That's all the time we have for you on this episode of Consider This. I'm Melisa Idris, signing off for the evening. Thank you so much for watching, and good night.